My name is Muhammad Athar. I am a radiologist affiliated with Scott Medical Imaging. The purpose of today's presentation is to make yourself familiar with knee MRI examination, and I will show you some common abnormalities that we encounter on the knee MRI. The common presentation is that a patient comes to a clinician with recent injury to the knee, and the clinician orders some plain X-rays. If the plain X-rays are negative and patient's symptoms subside, then there is no further investigation needed. However, if there is some internal injury and patient's symptoms persist for 2 to 3 weeks, and if the knee is swollen, then we need to suspect that there is some internal injury, and MRI examination may be very helpful in that situation. There may be an occult fracture, the knee may be unstable, or in case of patients who have history of jogging or long distance running, then there may be some stress fracture that may not be visible on the plain X-ray. So, on this slide I am showing the menisci, which are semicircular cartilages interposed between the femur and the tibia. These are fibrocartilaginous structures which are commonly injured in fast sports related injuries. The mechanism of injury to describe the traumatic forces can result from contact or non-contact injuries. In the contact injuries, the knee suffers a direct collision with an external object such as the dashboard of a vehicle or an opponent's boot or helmet. In non-contact mechanism, there is twisting or buckling of the knee. So, here what I am trying to show is that the tibia is rotating externally in relation to the femur. So, this is a pivot movement which is commonly occurs in sports related activities. On the next slide, the pivot may be the opposite, that the tibia is rotating internally. So, the location and severity of the structural damage depends on multiple factors, including not only the direction and magnitude of the force, but also the position of the knee at the time of injury. The compression and tension are two basic loads that commonly act on the knee. In compressive load, the bones collide with each other, and if the compression is sufficient, then there may be either cortical fracture or there may be damage to the interposed soft tissues, most commonly the articular cartilage and the meniscus, when they become entrapped between the bones. In tensile load, on the other hand, the bones pull apart, leading to distraction across the joint and traction on stabilizing structures. The tensile load can cause ligament and tendon tears as well as avulsion fractures. So, here is an example of a compressive load causing bone marrow edema at the lateral tibial plateau, and there is a small cortical fracture. On the opposite side, there is increased T2 signal in the deeper part of the medial collateral ligament, secondary to a minor ligament strain. This is another example of a compressive load causing bone marrow edema in the lateral femoral condyle, and then there is a small fracture in the subcortical bone. This is another example of a subchondral fracture at the distal part of the femur, and there is another fracture at the upper part of the tibia. This patient fell on ice and the plain X-rays were negative. There is a tiny subcortical fracture which was not visible on the plain X-ray. The menisci appear as triangular areas of low signal on sagittal sequences. This is an example of the anterior part of the lateral meniscus and the posterior part, and here is the medial meniscus, the posterior part. When there is sufficient injury to cause the meniscal tear, then we see this increased T2 signal which extends through the articular surface. If the injury is less than sufficient to cause a tear, then there may be contusion within the substance of the meniscus. Quite often the meniscal tear will be associated with joint effusion. This is an enlarged suprapatellar bursa which has fluid in it. This is an example of a longitudinal tear within the medial meniscus, and on the coronal scan we see the tear over here. There is a tear called bucket handle tear. In that case, the inner part of the meniscus is torn and displaced medially. So, this is the displaced part of the meniscus. It shows as a low signal area close to the intercondylar notch, and on the sagittal sequence it appears as a low signal area next to the posterior cruciate ligament. This is an example of a tear in the discoid meniscus. Sometime it will happen that the meniscal tear will be horizontal in shape and the joint fluid will leak through the tear and accumulate in this subcutaneous tissue and form a cyst. This is called as a parameniscal cyst. Now, another common injury is the anterior cruciate ligament tear. This is an example of a normal ligament which shows as a band of decreased signal. It is attached to the anterior part of the tibia and superiorly to the medial surface of the lateral femoral condyle. In a patient with a complete full thickness tear, we see this increased T2 signal in place of the normal ligament. This is an example of avulsion of the anterior cruciate ligament from the tibial attachment. The ligament is retracted superiorly. This is an example of a full thickness tear of the mid part of the anterior cruciate ligament. The injuries to the posterior cruciate ligament are less common compared to the anterior cruciate ligament, and quite often there will be other injuries associated with that. So, this is a partial thickness tear showing as increased T2 signal at the posterior part of the posterior cruciate ligament. This is an example of a complete full thickness tear. The ligament is avulsed from the femoral attachment and is retracted posteriorly. This is an example of avulsion of the posterior cruciate ligament. The avulsed bone is showing over here and the ligament is retracted superiorly. The medial collateral ligament injuries are graded as 1, 2 or 3. In grade 3 tear, the ligament is completely avulsed from the tibial attachment and is retracted superiorly. The lateral collateral ligament tear is less common. Now, here we have this increased T2 signal in place of the lateral collateral ligament. there is a condition called osteochondritis dissecans. This is a joint condition in which the bone underneath the cartilage dies due to lack of blood flow, is commonly related to trauma and is more commonly seen in children and adolescents. The area of the bone which is affected is low signal here. Now, in this patient the superficial cartilage is intact, but sometime it will progress that the cartilage and the bone may become loose and will cause difficulty in movement secondary to a loose body. The spontaneous osteonecrosis is a condition more common in females and is commonly involves the medial femoral condyle. This is an example of a patient with edema and osteonecrosis in the beginning. This is same patient with increased T2 signal. This is an example of a stress fracture at the upper end of the tibia in a patient who has history of long distance running. The plain X-rays were negative, and here we have the area of decreased signal on the T1 sequence. So, this is another example of a full thickness tear of the anterior cruciate ligament. Now, this is another example of a medial collateral ligament tear. There is increased T2 signal in place of the ligament. Now, sometime that patients who have tibial plateau fracture and there is an reason for pre-op planning, then the orthopedic surgeons, they may want to do the CT with coronal reconstruction. So, in that situation CT is commonly being performed for pre-op planning. Now, if you suspect that patient has a popliteal cyst, then ultrasound may be sufficient for that purpose. To summarize, the knee MRI examination is very helpful in patients who have history of recent or subacute trauma and you are suspecting internal injury to either the menisci or the ligaments, or there is some suspicion of contusion to the bone or an occult fracture, or in patients who have history of jogging or long distance running, if you are suspecting a stress fracture, in that situation MRI is very helpful also.